The American Hospital Association, AHA, is committed to supporting and advocating for organizations that are tackling the opioid crisis. One of the ways AHA does this is through developing and highlighting effective strategies, tools, and resources to help stem the tide of the opioid epidemic. Welcome to Advancing Health, a podcast brought to you by the American Hospital Association. I'm Tom Hetterly, Senior Writer in AHA's Washington office, and your podcast host. Today, we're talking with Dr. Reb Close, who is Lead Clinical Physician for the Monterey County Prescribe Safe Initiative. We'll be discussing how collaboration, in her experience, has helped unlock strategies to prevent opioid addiction and improve outcomes.
Welcome to another in the American Hospital Association's ongoing series of podcasts, where we learn how clinician and administrative leaders are navigating pressing healthcare issues. I am Rebecca Chickey, Director of Field Engagement, AHA Section for Psychiatric and Substance Abuse Services. And today we are talking with Dr. Reb Close, who, as the lead clinical physician for the Monterey County Prescribe Safe Initiative, is on the front line working to address the opioid epidemic as part of the Prescribe Safe Initiative. We'll be discussing how collaboration, in her experience, has helped unlock strategies to prevent opioid addiction and improve outcomes. Dr. Close, welcome, and thank you so much for talking with me today.
Thank you for having me.
Oh, you're very welcome. To kick us off, first tell me a little bit about yourself, your current role, and what drew you to the Prescribe Safe Initiative.
I am an emergency physician. I trained in Los Angeles, and I came to Monterey in 2003 to start my career as an ER doc in a non-academic institution, but in community practice. It was really important to me to be out in the community and to be part of it, and more of the community of emergency medicine. And as much as the academic institutions and the ivory towers are fascinating and beautiful and wonderful things happen there, I really wanted to be in what I kind of more think of as the pit, kind of right at the front line of what's going on. And so when I started here in 2003, something that was really surprising to me was we were dealing with, even at that time, so many years ago, it seems like now in this epidemic that we're better understanding, that we were dealing with a lot of substance use and dependency that was really, as of yet, completely undiagnosed and misunderstood. And so how I became involved in this is really out of necessity. So I'd go into my shifts. I was ready to take care of anything that came my way, and something was coming my way that I didn't really well understand. And it was basically that people I felt who were my cohort, young adults kind of at the prime of their lives, I saw them suffering, and they were having difficulties with procuring medications, and they were in for recurrent complaints that didn't make a lot of sense and didn't seem to have I didn't feel like I had the whole story. And so back in 2006, we started looking at these particular patients as a patient question and saying, well, what's wrong with, Jan? Why is she presenting over and over and over and over and over with abdominal pain that we can't figure out? And I look back at that now because at the time we started trying to figure out, well, how can we help her? Does she need to see a certain specialist? Does she need a new kind of medication? What does she need? Because ultimately what was always happening is she was getting opiates and she was feeling, that's in my proverbial air quotes, so she was feeling better. And now I realize, as I learned so much more, is we were treating her withdrawal. And so we started approaching it as a patient issue so many years ago. Is how can we help her? What services can we bring to her? And ultimately, it was a patient of mine many years later that taught me. She said, you don't realize I've been diagnosed with opiate bowel syndrome. She took herself to the Mayo Clinic because nobody could figure out her abdominal pain. And she took herself to the Mayo Clinic, and that was the first I'd actually heard of opiate bowel syndrome. She taught me. And so as our patients always do, we learn from their experiences and what they go through. And so I started researching and educating myself more about it. And then as time was going on, I was realizing there was this entire problem that we were starting to learn about. And so I took her experience and we started trying to take the experience of all these patients that we had been treating individually as what can we do to help this syndrome for you that we don't understand. And then there was a very pivotal case for me of a 19-month-old child that came into my emergency room and ultimately died from an opiate overdose. And I realized that this had become so much more than we could do on an individual basis. Jan, here's the problem. Steve, here, what can we do for you? There's something huge here. And so we reached out to a colleague down in San Diego who was kind of in a parallel world. They were working on it as well. And we reached out, and it was Dr. Ronit Lev, and she shared with me what they were doing and how they were trying to approach it instead of on an individual patient basis, but on a system basis. And they were looking at the bigger issues like my patient had taught me about. And that's how this whole thing started for us. Dr. Tony Chavez, one of our administrators at my hospital, he and I started talking and realized, well, wait, there's so much more to this than we understand. And so it was just a tiny little team of us realizing there was an amazing issue that had to be addressed, or we were going to continue losing so many people in our community. So it really started out of complete necessity of watching people suffering and trying to come up with what we do about it.
What a journey. And
that's crazy. It has been.
As you spoke, the overdose of the 19-month-old, that really does, I hope, cause everyone listening to this podcast to pause and realize that this epidemic has no bounds, ages, socioeconomic, ethnicity, etc. I'd like to build on the outreach that you spoke of, reaching out to your colleagues in another city, only to learn, unfortunately, that they were facing the same epidemic. I think that may have been one of the foundational steps that allowed you to recognize and to say, we have to do this in collaboration with other organizations. You noted that you can't just do it a one-off. So as this work has evolved, were there key relationships that you thought were important to cultivate during the initial launch of the Prescribe Safe Initiative? And if yes, what were they and how have they changed?
So yes, we realized, and specifically when I was chatting with Dr. Lev down in San Diego, we realized that if we were going to affect a change in our community, it couldn't be just one or two parts of the community. It had to be everybody. And so Dr. Chavez, my administrator, he and I chatted about it and used an analogy that I absolutely love, is that if you squeeze a balloon in one area, it expands somewhere else. And so we decided, and fortunately for us, Monterey County is relatively small. There are only 4 hospitals in our community, and ER docs tend to be a pretty tight little group anyway. And so we decided that, okay, we've got to go for everyone that we can pull into this from the beginning, because we don't know who's going to make the change, who's going to have the great idea that's going to move us forward, who's going to have the connection. Let's just bring everyone to the table and see what we find. And so we approached all 4 of our hospitals. He approached the administrative side. I approached the ER side. We approached our law enforcement agencies because we realized they're on the front lines as much as I am, if not more in some respects. So I also discussed with our sheriff coroner's office, as we had developed a relationship over the years, when I would call to report yet another death from suspected overdose. We have a deputy district attorney for healthcare fraud, and we approached her and asked if she would have some interest in coming to the table initially. We reached out to who we knew, the ER, the law enforcement. I reached out to the firefighters because we see them in the ER all the time.
Sure.
And I asked, and I did the cold calls. I said, I got a question. I called one of the fire chiefs, and I got a question. We're looking at this issue that we're seeing in the ER. What do you think? And not a single person that I cold called didn't have an experience, didn't have something to add or to say. Everybody wanted to be part of the effort. So we started with that first group of kind of, who are your friends? Who do you know? Who do you feel comfortable reaching out to? And who do you think has a vested interest in the community and in our group? And it was 100% positive, the responses that we received. And then what was amazing is from that, like I said, everybody seems to know someone else who would also have a vested interest in working in this collaboration. And so we've just expanded from there and pulled in a number of other groups into this overall effort.
So who coordinates and funds the collaborative work? the big elephant in the room. Has anything unexpected emerged from these new collaborative relationships?
Yeah, it's really interesting. So the first few years were completely it was all volunteer. It needed to be done, and so we just did it. That was how it started for the first few years. There weren't a lot of operating expenses. We asked ConMar at my hospital to help start making signage. And again, because everybody can see the value of the effort, it was taken care of because it was important. And so there wasn't a budget for it because there wasn't a big budget. As the work continued, fortunately, my hospital is able to give us an administrative stipend because they see the value in this work. So we help with that. We have then, I was in a meeting, several years ago now, and there was grant funding for drug bins. And that was another thing on our list of, we've got to get the drugs out of the house. We've got to get medications that are unneeded and unused safely disposed of. And the Rose Foundation had money for drug bins in our county. And so I raised my hand and asked to be part of that. And we were able to get that. Our hospital employees had the opportunity to have some of their payroll funds go towards donations to nonprofit organizations. And so the employees chose Prescribe Safe from what they were seeing happening in our community, and they donated some funds. Our foundation, and I know they've been a big part of working with us on our webinar that's coming up. Our foundation approached us and we approached them and have asked for help with various projects. Ironically, it's really low budget for all the things we're doing because everybody still wants to help, pitches in, takes some time, and works to make it happen. As we've added in other groups, one of the relationships that wasn't one of the initial people we approached, but say, hey, by the way, did you guys reach out to the dentist? We've become collaborators with the Monterey County Dental Society. So they've had us come speak. They've made all the flyers. They've taken care of the promotion of information for their group. So it's been in some ways that each task that's come up or each group that's been approached, everybody works within their own budget and their own effort to make things happen. So it's been quite it's like the initial group it's almost a little hodgepodge as you call for help and then they phone a friend and we all just bring it together.
Sounds like you've got an intricate phone tree going on. Who's at the top of that phone tree, to keep that analogy going? So who coordinates this collaborative, and how do you think the collaborative has proved helpful in advancing the Prescribe Safe interventions and impact?
To be honest, the main contacts for our program are myself and Dr. Grover. Those are the two people. Everybody knows if you have a Prescribe Safe question to contact us. And we field it. If I have a question for Dr. Chavez, or if something that I don't know how we can expand it, I need to talk to, Dr. Willis and Marin, or, we are the center of this effort. And I think that's made us also very successful, is people know that if I don't know the answer, I know who to ask, or at least how to get us started. And keeping it kind of simple in that regard, I think has been really helpful.
Absolutely. And for those listening to this podcast, we are also doing a podcast with Dr. Casey Grover as part of this series to really allow you to get in depth with the Prescribe Safe Initiative. So I assume that the podcast with Dr. Grover will be posted similarly with this podcast from Dr. Reb Close. So let's bring it home in terms of reality. What aspects of the Prescribe Safe's collaborative approach do you think could serve as a model for others? Similar situations, they're in their hospital or maybe they're a community-based organization and they are struggling with how to have a real impact on the opioid epidemic. So what do you want to share with those listening now? What are the aspects of your model and any lessons learned that you'd like to share?
I think the one thing to realize is this affects everybody. There is no person that I have approached either on a systems level or in personal conversation that isn't impacted by what's going on. And there's no fear, I think, of rejection. I know it sounds funny, but this is so much better understood than it was 10 years ago or 13 years ago when my charge nurse and I were trying to figure out what was going on with this young group of adults that were having so much trouble. So I think that's one thing, is to realize when you reach out for help, people want to help. Everybody wants to know what could they do. That's been my experience universally. The other thing is I think listening to the ideas that come from each of the people you talk to. So we didn't initially realize the power in reaching out directly to our pharmacists, but truly, as our collaborative efforts have gone on, our pharmacy colleagues, I can't tell you how many times a day I'm texting with them, asking questions of, what do you think about this? Are you concerned about this? Talk to me about this medication. How can we make this more clear for pharmacists and prescribers, our communications? So it's reaching out and realizing everybody has parts that they can add. We initially didn't reach out because we didn't know. We were growing this community to the drug treatment programs. They have become, oh my gosh, critical partners in how can the need be felt? What can we do to make it better? Like I said, with our dentists, another thing is how do we treat pain? Because obviously pain didn't go away. A lot of this started from physical pain, chronic pain treatment with only one modality, which was opiates, which was what we were all taught decades ago. But wait a minute, there are many other ways to treat pain. So reaching out to our complementary providers, reaching out to our pain specialists, reaching out to alternative, I actually prefer the word complementary, but what is traditionally thought about alternative practices, realizing that you can't, another analogy that one of our docs uses is, you can't tell me that, no, we won't use opiate situation. You got to tell me what we can do. And so we change that whole thought process. It's not just, no, we aren't going to use this medication, but here's 10 other things we can do for you. A lot of our guidelines have come from a particular provider or a person's experience saying, hey, how do I talk to my kid if I think they're experimenting with prescription drugs? Oh, wow. Yeah, let's talk about that. There's got to be resources for that. Let me reach out. Let's find out. What can we do? Nothing's off limits, and everybody has something to add. And I think that's the thing, is looking for help throughout the community because it's there.
Dr. Close, that is incredibly inspirational. I just want to echo a couple of things that you said there. One, that everyone you reached out to for help said, sure, we've seen this challenge, we've seen this problem, and we want to help. And that you need to truly value and listen to those other voices who are willing to work together collaboratively to address this program. And then another message that I think you just shared is that the growth of your collaborative continues to evolve, who the members are. And so always be looking for that other opportunity for organizations or individuals to help pitch in. So today, I just want to thank you so much for taking your time, your willingness to share your expertise and insights.
It was a pleasure being here.
And I also want to thank those listening in on this podcast. We hope that this will inspire you, has given you some meaningful steps that you can take to implement part of this in your own community. I also want to give a nod out to our March 12th webinar that will feature not only Dr. Close, but Dr. Casey Grover and the head of the foundation that Dr. Close mentioned earlier. It will give a broad look at Prescribe Safe's initiative Start, Impact, and Goals. And finally, if you want to learn more about the work that the American Hospital Association is doing to address the opioid crisis, simply go to www.aha.org/opioids. Thank you so much.